All right, everybody, we're ready to get started. We're very excited to have Dr. Julie Vose here. Dr. Vose is an international expert on lymphoma. She's a professor at the University of Nebraska Medical Center, where she has spent the majority of her career. I'm going to hit on a few of her accomplishments here. There are many. Notably, she's the co-program leader for a lymphoma research program at the University of Nebraska Medical Center. She's also the associate director for clinical research. She's a member of the ASCO Professional Development Committee from 2010 through 2013. She's the co-chair of the Lymphoma Steering Committee for the NCI from 2009 to 2016. She's been a member of the ASCO Board of Directors from 2010 to 2013, a member of the UNMC Physicians Board of Directors from 2011 to 2015, and she served as president for ASCO from 2015 through 2016. So you can see Dr. Vose is very accomplished, and we're very excited here to have her at Grand Rounds. She'll be talking to us about novel therapies for non-Hodgkin's lymphoma.
Well, thanks very maybe a little too high. Thanks very much for the kind invitation to come and visit, and I appreciate the opportunity to be here again. I've been here several times, although it's been a few years since I've been here, so good to catch up with all my friends here at Emory and Winship Cancer Center. So today I'm going to talk a little bit about update on novel therapies for non-Hodgkin's lymphoma, and obviously couldn't possibly talk about all of them, but I'm just going to talk about a few different areas and kind of the background behind where I think this field is going. These are my disclosures. So I think the most important concept of lymphoma is really understanding lymphoma. And wasn't so long ago, maybe just a few decades ago, that there were many less types of non-Hodgkin's lymphoma. Hodgkin's has always been about the same, so we haven't expanded that too much. But non-Hodgkin's lymphoma has really expanded into understanding the different types of lymphoma, and therefore potentially understanding the concepts behind different treatments for the different types of lymphoma. So the WHO classification, of course, has changed in different malignancies every so often. And just recently, the 2016 WHO classification was updated. It was published online in 2016, and just recently it came out in hard copy, and that's available for being able to buy that now or online. But it really helped us to try to understand the different types of lymphomas, the pathways in the lymphomas, to recognize the lymphomas as well as the patient characteristics. And I think this is going to be the first step to the next improvement in our care for our lymphoma patients. So first I'm going to talk just a little bit about T-cell lymphoma. And that, of course, is much less common than B-cell lymphomas. It represents only about 10 to 15% of all non-Hodgkin's lymphomas. This is from a large international study we did several years ago and published in 2008, looking at 22 different sites internationally, different types of lymphoma classification. And this classification has even changed since then. So we're going to talk a little bit about how that's improved since then. But about 25% of patients were peripheral T-cell lymphoma, not otherwise specified. And that's just kind of a big basket term of different types of T-cell lymphomas that we're understanding. Really, there are many different subtypes within that classification. And then the second most common type, angioimmunoblastic T-cell lymphoma, also has probably several different types in it. But it's very important because there's different pathways that are important in these different types of lymphomas that we can potentially target with some new agents. So the outcomes for patients with T-cell lymphoma are very poor in most cases. The anaplastic large cell ALK positive has the best prognosis, ALK negative, kind of intermediate, and the rest really, unfortunately, very, very poor prognosis. And this is from the original publication in 2008, but we also recently did an international kind of update of this prospectively. And unfortunately, other than NK T-cell lymphomas, which have improved because of the use of L-asparaginase, most other of the lymphomas, the identical overlap to this curve, unfortunately. So we have a lot of ways to go to improve this. So the update on the classification, I'm just going to point out a few different areas that I think are important to try to identify and then use this information to try to improve our outcomes for patients with lymphoma. So kind of one area that's always been interesting is wide variation. Some T-cell lymphomas do very bad, and then there's a few of the cutaneous T-cell lymphomas, of course, that do quite well. And this was really updated in this last classification where they really culled out this, in previous classifications, 2008, was called the small to medium CD4 positive T-cell lymphomas. And these always behaved very indolently. In the current classification system, they actually have culled out some of these very indolent categories that they don't even think maybe are lymphoma and have called them lymphoproliferative disorder. So this has changed to cutaneous CD4 positive lymphoproliferative disorder in the most recent classification. And the recommendation for this type, if it's a single lesion, is just to do excision of that or potentially radiation if the entire lesion hasn't been excised. And many of these patients really don't have a recurrence of that, or if they do, they can be treated again very indolently. So the new classification has really helped in trying to differentiate some of these different types of cutaneous lymphomas that are either very good or very bad, and potentially help us target the different lesions. One other area that's, I think, really an important improvement in the new classification is grouping of the nodal peripheral T-cell lymphomas with the T follicular helper lymphomas. And this would include the angioimmunoblastic T-cell lymphomas, as well as some peripheral T-cell lymphomas that have those same characteristics. The important part of this is that these all share the mutations that are common in some myeloid neoplasms, specifically the TET2, IDH2, and some of the other characterizations that we can perhaps target with some of our agents that we use for myeloid neoplasms. So with this current understanding, I think we'll be able to utilize this in helping our patients to get more specifically directed therapy. So the T-cell lymphomas have always been a little bit more difficult to study, of course, because it's hard to get enough samples to study to be able to do that. The Leukemia and Lymphoma Profiling Project, which we were a part of for many years, has, over the last few years, been able to gather enough samples to do that. And this is published by Javeed Iqbal, who's from our center, and used some of the samples from the Leukemia and Lymphoma Profiling Project. And so we're starting to understand the different types of lymphomas and maybe how we can potentially understand them and target them. So in the molecular analysis of this, there were two major subtypes and then a third unclassifiable one of the peripheral T-cell lymphoma not otherwise specified. And the types that came out of this classification include one that was called GATA3, and that was about a third of the cases. And these particular cases have a very poor clinical outcome. The pathways that really have found to be highlighted in these are the PI3 kinase pathway and mTOR pathways. So I think with future clinical trials, we'll be able to use this information to try to molecularly analyze the specimens and then maybe do targeted therapy with this classification. Then about 50% of cases are the TBX21 subtype, and they have more of a cytotoxic cell signature. These do have a poor outcome as well, but perhaps a little bit different than some of the other ones. And these really have the pathways of the NF-kappa B and STAT3 pathways that are a little bit more important. So you can see if we could perhaps prospectively be able to analyze specimens with peripheral T-cell lymphoma and then differentiate the treatments for these patients in a similar fashion where we're doing that in B-cell lymphomas we'll talk about later. This is just at its very infancy, but I think is something in understanding the lymphoma that we need to do going forward. And then, of course, for outcomes, the GATA3 have the worst outcome. TBX21 have still a bad outcome, but a little bit better, and this unclassifiable somewhere in between. So hopefully with targeting, we can try to improve upon all of those. So some of the new targets that are being looked at then in these types of lymphoma, for example, the IDH2 mutation, this of course has now become very important in the myeloid area, but also specifically in the T follicular helper cell or angioimmunoblastic T-cell lymphomas. This is often an area that is abnormal and can potentially be targeted, as well as some of these other areas that we talked about previously. So hopefully with this information, we'll be able to improve our targeting agents for these patients in the future. And there are clinical trials going on with the IDH2 inhibitor in this particular subtype, although it's difficult to do because these patients are so rare. The other areas for T-cell lymphoma that potentially could be targeted, again, would be looking at the PI3 kinase inhibitors, JAK inhibitors, mTOR inhibitors, demethylating agents. So perhaps by trying to classify and then put in a large basket trial, we can be able to subclassify these patients and put them in better pipelines. But we're all going to have to work together to be able to do this optimally, because there's really not enough patients at any one center to do that, unfortunately. Now switching to B-cell lymphomas, I think there's a little bit more headway in B-cell lymphomas and understanding them. They're a little bit more common, and specimens are easier to find. So probably the biggest concept that's been different over the past several years in B-cell lymphomas has been distinguishing the cell of origin into the germinal center B-cell-like or activated B-cell type or non-germinal center B-cell type, originally using the areas of gene expression profiling. And of course, the leukemia lymphoma profiling group did that as well many years ago. However, it's really not very practical to do the original gene expression profile because you have to have frozen tissue, which of course many centers unfortunately do not. So immunohistochemical analysis came about, and there have been many different classification schemes for that. The one that's most commonly used is the Hans method, but that's about 25 to 30% inaccuracy when using that method, and so it's definitely not perfect for sure. So the new classification really calls out these different cell of origin, specifies these, and eliminates some of the other kind of basket ones that were included. So there used to be a classification called B-cell lymphoma unclassifiable. That's actually been taken out of the new classification. And then, of course, more importantly, it recognizes the high-grade B-cell lymphomas with the c-Myc and BCL2 and or BCL6 translocations, so-called double or triple hit lymphomas, that we've now recognized as being very poor prognosis. So we recognize a lot of these things. I will have to say, and we'll go over the studies, we don't know exactly what to do with this information yet, and so that's the next step, of course. Then there's another category, the high-grade B-cell lymphomas that include what was formerly called the B-cell unclassifiable, but they lack those translocations, and that's another classification in the new system. So the cell of origin, of course, originally the gene expression profiling showed us that the patients with the activated B-cell subtype did quite a bit worse, and still continues to hold up over time, although both curves have perhaps shifted upward. Immunohistochemistry, again, about a 20 to 30% error rate based upon this. The Hans algorithm is probably the simplest. There's several other newer classifications that perhaps add or change a little bit of the different stains that are done, but still has about a 20% misclassification rate with using that methodology. But why is this really important? We've always known that there are different types of diffuse large B-cell lymphoma in the old classification system. Some patients did very well. They behaved indolently. Some patients were super aggressive and grew very quickly. We never in the past understood why. Now I think we're trying to understand that and realize that is based upon really the distinct biology of these different types of diffuse large B-cell lymphoma. So the patients that have the germinal center B-cell type, they have pathways that can perhaps be targeted, as now we're understanding based upon the scientific methodology, looking at some of these different pathways. For example, EZH2 mutations are seen in the GCB type of diffuse large B-cell as well as follicular lymphoma and can potentially be targeted, as well as some of these other areas as well, BCL2 translocations or mutations. And then the activated B-cell subtype have different types of mutations or abnormalities that we can target, such as the ID88 or the CD79A and B. And then the primary mediastinal B-cell have, yet again, targets that we can use with other therapies that we'll talk about in a minute. So really understanding the type of lymphoma is really key to targeting the specific treatment for that patient. So tumor heterogeneity, again, very well known for a long time, understanding more and more of this, and I'm sure we'll understand even more next time I come back to talk. That the germinal center B-cell type and activated B-cell type are different. They behave differently. And we have what we call double expressor lymphomas. That could be either an activated B-cell or germinal center B-cell type. That's where the immunohistochemistry is positive for that. That does not necessarily predict, however, for the mutations. So the double hit lymphomas are mostly in the germinal center B-cell subcategory, which typically we think of as being better prognosis. But the double or triple hits, in that case, are worse prognosis. So important to understand that differential. And we need to be able to understand that when we're looking at expression versus looking at the mutations that we're testing for. So again, most of the patients that have the double or triple hit are within the GCB category, and most of the patients that are double expressors, 2/3 are ABC and 1/3 GCB. So we need to not rely just upon immunohistochemistry, because that will be misleading in some cases. We actually need to do FISH on all of our specimens with diffuse large B-cell. Now, some centers only do the FISH in cases that are germinal center subtype, and that's a way to try to reduce the number of testings you're doing. So that's another possibility, although the recommendation by the WHO is to actually do FISH on all diffuse large B-cell for c-MYC, BCL2, and BCL6, so that you don't miss any of those patients. So outcomes based upon this information, the patients that have the double hit, in this line here, very worse prognosis. This is mostly with R-CHOP type therapy. The patients that are the double expressors, sort of intermediate, and then the others. And this is held up in multiple different studies using R-CHOP type treatment. The question is, can we improve upon that with any other types of treatment? And that's still an unknown question, I would have to say. The other areas are, do the double expressors and the double hit or triple hit have different clinical characteristics? And definitely the double or triple hit by FISH are much more aggressive and do have a worse outcome. They also have a higher evidence of CNS disease. And it's been a question of whether the double expressors behave differently. And at least this study from British Columbia shows that even the double expressor lymphomas have a higher incidence of having CNS lymphoma. And so now many centers are going to CNS prophylaxis, not only just with the double or triple hit by FISH, but also with the double expressor lymphomas. So as we understand more about the biology, we can hopefully improve the treatment with this sort of information. And we're learning more and more as we try to collaborate together to understand these kind of more rare types of lymphomas. This was from a multi-center collaboration that was published several years ago, looking at outcomes in double hit or triple hit patients and trying to do some of the multivariate analysis for outcomes. So some of the common things that we look at definitely showed in the multivariate analysis, and some other things. So high white count, which we normally don't necessarily think of, high LDH, of course, stage, and CNS presentation, of course, portend for a worse outcome. But a little bit surprisingly, if the patients had 0 of these characteristics, their outcome was pretty good, even if they have a double hit or triple hit lymphoma. So the majority of patients fit into these categories, of course, and have a worse outcome. And this is based by standard IPI. So using that, at least analysis in the double hit or triple hit lymphomas does classify patients into at least one category that has a pretty good outcome that you can treat with standard of care therapy. So now getting back to the classification, this sort of makes it very complicated because they've had all these new categories, and a lot of the patients that were given these characteristics in the old classification now fit into different classifications in the new classification in the 2016. So when you're doing a retrospective analysis, you may have to actually go back and reclassify all of the previous biopsies that have been done, which makes it a little bit sticky to do. But if you're going to be really doing a prospective study and trying to look back at what a retrospective analysis of that patient population is, we're going to have to do that, unfortunately. So question is, what's the best therapy for these patients? And many of the prior studies, of course, R-CHOP is always the standard of care, and we use that as the control arm in all of our studies. And there have been lots of different studies looking at trying to improve upon that for diffuse large B-cell lymphoma. The one study we were waiting for years and years and years, of course, was this one, the CLGB study of R-CHOP versus dose-adjusted EPOCH-R, based upon the NCI study that this did better in diffuse large B-cell lymphoma. And this was presented last year at ASH, where the event-free and overall survival by randomization was identical, and unfortunately did not prove that dose-adjusted EPOCH-R overall was a better treatment. The subset analysis from this, as far as different subtypes using the FISH, diffuse large B-cell subtypes, cell of origin, or the double or triple hit is still pending, and I'm sure we'll be seeing some updates of that at ASH this year. But at least overall, all comers, no benefit from dose-adjusted R-EPOCH. And there have been lots of different ways to look at that. And again, some of the subtypes that we think may benefit from dose-adjusted R-EPOCH, such as primary mediastinal B-cell. Again, there's only 28 patients in this particular study, so we're not going to get the answer from this because it would be underpowered for that, unfortunately. But there are other centers that have continued to use dose-adjusted R-EPOCH for the primary mediastinal B-cell. We do as well, and feel that it does have a better outcome for those patients. So more recently, there have been studies looking at all different types of changes or modifications or additions to the standard CHOP backbone. This was recently published and looked at R-CHOP, again, as the baseline or the control, versus adding to it obinutuzumab CHOP for diffuse large B-cell. And again, all comers, absolutely no difference in the diffuse large B-cell for overall survival or progression-free survival. They did the subclassification and did show that patients, again, with the GCB subtype did better compared to ABC patients overall, but no difference by treatment assignment. So this one was a bust, unfortunately. And there have been lots of similar studies trying to add to the CHOP backbone. This was one that was published by Dr. Leonard's group recently, trying to add bortezomib to the CHOP backbone, and vincristine was taken out compared to R-CHOP. Again, unfortunately, no difference in outcome that by randomization. But why is this? Why do we do this? These studies, of course, didn't have a lot of the classifications that we currently use and didn't try to take patients by their cell of origin or subclassification. And therefore, potentially, this is a confounding factor in these trials. So many of these trials were not stratified by the cell of origin for GCB or non-GCB. And there could have been inadvertent inclusion of the double hits, although it should have been, because it's a randomized trial in both arms, and probably a mixture of double expressors and triple hit. And they were really not powered to look at this. So in order to really define this, we're going to have to do a prospective study with these specific subtypes that we now understand. So there have been lots of attempts to improve upon R-CHOP overall for diffuse large B-cell. And unfortunately, R-CHOP 21, after decades of use, still is a standard of care overall. But how can we try to improve upon this with our new knowledge? I think that's the way of the future. So looking at kind of dose intensification strategies for double or triple hit, which is really the patient population that's the worst, there have been several multi-center retrospective studies looking at different options for patients. And I would say that kind of the take-home message is that in most of the studies, an intensive type of regimen, such as the dose-adjusted R-EPOCH or hyper-CVAD or Codax-M IVAC, has in general been better compared to the R-CHOP. So at least at our center, for these types of patients, we're currently using dose-adjusted R-EPOCH. There have also been some studies trying to look retrospectively at early transplantation in these patients. I would say it's controversial at best. We still consider these patients for early transplantation and first remission, but some of the studies demonstrate that if the patient is in remission, that perhaps they can do okay. And so I would say this is still a controversial area. So there's a spectrum of patients with diffuse large B-cell that have been included in most clinical trials, but we really need to understand that these are not the same patients. Many of the patients are excluded due to concerns about delays or risk, and there's a study that I'm going to go over in a minute that shows that patients that get their treatment quickly probably and don't get to clinical trials actually do worse because they probably have higher risk disease. And then we have this other population that can be randomized, but there's a lot of different subpopulations within that population. So we need to try to understand that and adjust for that prospectively. So this is an interesting poster from ASH last year, actually, that showing that patients that got clinical trial, there was clinical trial bias because patients that got treated very quickly actually did worse. If they got treatment within 7 days or within 14 days, they did worse if patients got treated later, probably because they have less aggressive disease and they were able to actually get into the trial. And so I think this is important when we're looking at trials and designing trials. A lot of the trials that we're doing nowadays need to have pathology review. They need to have a lot of these molecular analysis, and that takes time. And so the patients that actually get into the trial are often the less aggressive patients, leaving us with more aggressive patients that we need to have better potential trials for. So determining the cell of origin, again, there's lots of limitations to frozen material, just really not available in many places. We have a large frozen tissue bank at our center, but of course, most patients are diagnosed in the community, perhaps, and they don't have that available. IHC, we talked about the limitations of that, about a 20 or 30% misclassification. And so people have really been working on new ways to try to classify this quickly and accurately. So probably the best thing that's come recently is the nanostring technology, or LYMP2CX. And this is, I think, going to be able to come up and be very quickly something that replaces what we're currently doing. This is from the original study, and then there's been subsequent ones confirming this, that there's using this technology, there's a 98% concordance with the actual gene expression profiling. So a very good concordance rate, and I think that this is going to be replacing IHC in the near future. It also shows that compared to the other studies, that it's compared to the gold standard, the outcomes are quite similar, and they're going to continue to do this prospectively. We're currently, again, piloting this at our center with about 200 patients, and then we'll be taking it to prospective trials. The LYMP2CX significantly does help us classify this, and it's be able to identify the patients with the different outcomes. We'll be able to look more at the double and triple hit patients in a rapid fashion, and to try to help us with outcomes. FISH, of course, takes, depending on how you get the materials, can take up to 7 to 10 days sometimes, and that's difficult when you need to treat a patient immediately. The LYMP2CX has also been used in some studies where patients did not get R-CHOP, they got other treatments. And the cell of origin in using this particular regimen, the R-MEGA CHOAP study and the Recover 60 study, which were European studies, really did not demonstrate that much difference in outcomes for ABC or GCB. So it may be that perhaps using this technology there and using different therapies, we may have potentially very different outcomes. So those are things that we need to continue to monitor in prospective trials. But how can we move forward beyond R-CHOP? Because we've had that for many decades. And we need to really focus the trials based upon biology of the lymphoma, and this I think is true for all subtypes of lymphoma, but particularly diffuse large B-cell. This will lead to, unfortunately, smaller patient populations, subgroups, and we have to really work together to try to put patients on trials in order to get adequate patients to do this. And also to understand biopsies at relapse are very important, and to try to look at identifiable targets as well at relapse, which may change. So potential targets that are therapeutic in ABC type, we understand this type, I think, a little bit better than some others. Lots of different pathways, of course, to potentially target, some of which have already been looked at. Certainly the B-cell receptor pathway with ibrutinib, looking at the NF-kappa B pathway. A new area that's being looked at is the IRAK4 inhibitors. Lenalidomide, of course, has been utilized, and then ruxolitinib as well on the STAT3 pathway. So different subtypes of lymphoma may be able to look at some of these different modalities. Kind of what's information is available? Well, of course, lenalidomide has been around in myeloma for a long time, so pretty well understood. In lymphoma, it's been looked at and does have a response rate in diffuse large B-cell of anywhere between kind of 20 and 40%, complete response rate kind of in the teens. So as a single agent, it's useful, but not that useful. So it has been combined, however, with, in this case, R-CHOP. So this is based upon a pilot study that was done at Mayo Clinic, where lenalidomide was added to R-CHOP, so-called R-squared CHOP. And they looked at this compared to retrospective case match control. They found in their study that the patients with the non-GCB, so activated B-cell subtype, had a better outcome with the R-squared CHOP as compared to retrospective controls. This was not true with the GCB category. So this was taken forward then into a couple of prospective trials that we're still waiting for the information on. An ECOG trial where patients with diffuse large B-cell had the GCB versus non-GCB looked at by actual gene expression profiling and the immunohistochemistry. And then patients that were in the appropriate category were randomized to R-CHOP versus R-squared CHOP. And we're still waiting for the results of this study. But immediately, the company also took this to a much larger international randomized study because of that information from Mayo Clinic. And they took patients with diffuse large B-cell that were on the ABC type. So they were selected by gene expression profiling in real time. However, of course, this does take a little bit of time to do, so that's the selection bias a bit. So patients then were randomized to R-CHOP versus R-CHOP plus lenalidomide, R-squared CHOP. And you can see the stratification here. We're still waiting for the results of this study, but expect that it may be out in the next year or so. And this is a very robust trial, so we're hopefully that this will have some good analysis in it and maybe push the field forward if positive. This medication is also used in Europe. There's been some studies looking at lenalidomide as post-treatment maintenance in this subgroup of patients has been found to be beneficial. So we're going to continue to look at this and see if this comes out to be a positive study. The other very strong pathway that is based upon biology, of course, is the B-cell receptor signaling pathway. So Bruton's tyrosine kinase and ibrutinib, of course, has been around with us now for a few years. And we have some good activity in the activated B-cell subtype of diffuse large B-cell. So Wyndham Wilson published this a number of years ago based upon some of the very original studies that were done in diffuse large B-cell, showing that the patients with the activated B-cell subtype had a much higher response rate in the single agent compared to patients with GCB type. You can see their overall survival here was a bit better as well. So this information was taken forward to first a kind of a phase 1/2 type study where ibrutinib was added to R-CHOP. This was published by Anas Yunus, and found that it had a very high response rate and potentially no additional toxicity, not any significant additional toxicity, and the PK was really not affected. So this was then taken forward to a large prospective randomized study that we're still waiting for the results of, although accrual is complete. And this study used non-GCB, so that would be selected by immunohistochemistry in real time to make it faster. And then patients were randomized to the R-CHOP plus ibrutinib at the 560 milligrams versus the standard of care. And there were 400 patients in each arm, so a very robust study again. I understand that they just asked for another data lock recently on this, so I don't know if it's going to come out in the next year, but we're hoping that it might as well. So one of these two studies, or both, may be positive in that subpopulation that will be able to finally change the standard of care based upon the biology of the lymphoma. So with respect to the kind of trying to change the future of lymphoma care, I think it's really based upon the biology of the tumor and understanding that as we improve the classification of the different subtypes of lymphomas. This is really going to have a much better precision for our treatment for our patients and really develop these targeted therapies. And the goal, of course, is always to individualize our care for patients. We know when we see a patient in the clinic that really that there are no two patients alike. They behave quite differently. And we need to understand why that is based upon patient factors, but also based upon lymphoma factors and treatment factors. And that's kind of where we need to go in the future. So the impact on clinical trials, it's going to make it really hard for us to do historical controls based upon the old classification system because of the change in the diffuse large B-cell and also in some of the other subtypes of lymphomas. So if we are going to use historical controls, we probably are going to have to go back and reclassify some of those, unfortunately, to have an accurate control. And the unfavorable groups may be excluded from clinical trials just because they can't get to the clinical trial. So we need to have these classification systems that can be done rapidly and can be specifically confined to that specific subtype of lymphoma to get the best accurate outcome. Redefining testing is really important for different subsets of poor prognosis lymphoma. And obviously the Lymph2CX I think is very promising. I'm sure there'll be the next upgrade of that in a few years, but at least right now that looks like the most promising technology to be used throughout the system. So what's new for salvage therapy or next therapy? We mostly talked about frontline therapy previously for diffuse large B-cell. But certainly the CAR T-cell strategies are probably the most exciting strategy for relapse lymphoma. And I know that you guys had this here as well. And there are several different sort of flavors of the CAR T-cell. So in this case, there were several different trials looking at patients with relapsed and refractory diffuse large B-cell, and these were kind of the worst of the worst. They relapsed after autologous transplant or were primary refractory, and then had a standard leukapheresis done to be able to obtain the T cells, and then they had retroviral transduction with the anti-CD19 CAR. Patients then received the lymphodepletion, usually fludarabine and cyclophosphamide, and infusion of the T cells. And this has really probably been the most remarkable treatment in patients you never would have thought would work. I'll show you an example later of one of our patients. So there are 3 companies that have been working on this, more, but these are kind of the 3 that are out there. And of course, Novartis, Kite, and Juno all had different CARs. They have slightly different gene transfer methodologies, and of course, all of this started originally with research at different academic centers. And so Novartis has been, of course, approved for ALL and soon to be approved for diffuse large B-cell as well. And Kite has been approved recently for diffuse large B-cell. Juno is still working on different clinical trials. Just going to go over some of the data that's been presented over this past year for these different CAR T cells. They'll be updated at ASH in just a few weeks. This was presented by Dr. Nilapu at the Lugano meeting this year, and looked at the Kite product, Axicell, for patients with relapsed and refractory diffuse large B-cell. So just in short, these were patients that you would expect basically 0 outcomes for, very refractory patients, very difficult patients to treat. And if the patients had a complete response to this therapy, especially if they have a complete response kind of at 6 months, really there have been very few relapses after that time. If they had a partial response, they really did not benefit from this. So you really have to have a complete response to this therapy to be able to benefit. But there are some very refractory patients that have had some unbelievable responses that have been durable. The side effects from this therapy, of course, can be severe. This is from this particular trial that Dr. Nilapu presented. And the 2 kind of toxicities that are different for this are cytokine release syndrome, which involves inflammatory process in the patient, so they can get fevers, inflammation, confusion, and they have an increasing CRP. They can also have abnormalities, increasing ferritin, and just general inflammation. So it can be severe in some patients, and in this particular case, greater than or equal to grade 3 was about 15 or 20%. Neurotoxicity is when the patient can have generalized inflammation that can also include some abnormalities with confusion, seizures, ataxia, difficulty in walking, and in severe cases, they can not have any respiratory drive and have to go on the ventilator. And there have been some cases that have patients that have died on this study and others from the neurotoxicity. So it is a treatment that can't really be done easily in the community. It needs to be done at centers that have this capability, large transplant centers. They also compared the results of the Zuma trial to a Scholar 1 study, which was a study that retrospectively looked at a very similar patient population and found, again, this 6-month time point is very important, and the overall survival at 6 months in the retrospective study is about 55% compared to 80% of patients in the CAR T-cell study. So obviously not prospectively designed, but retrospectively in a similar patient population looks very promising. So the cytokine release syndrome and neurotoxicity are generally reversible, and typically the steroids are given in tocilizumab, which is the anti-IL-6 antibody, and they typically can be reversed, but patients have to be monitored very carefully during that critical time frame. There were some deaths on this study from HLH. The patient had a cardiac arrest, pulmonary embolism, and then some of the neurotoxicity. But as we recognize this more and more, we'll be able to understand which patients are at high risk and be able to monitor those patients better. The other study that was presented at Lugano was this study, the global trial of the CTL-019, which is the Novartis product, in the Juliet study, and this was presented by Dr. Schuster. So this product is a little different in that, and I think this is the one you had here, right? The product is apheresed and then frozen, whereas the other product for Kite and Juno are shipped fresh. And so in this particular study, this was a global study, so the frozen product obviously was much easier to use in a global study. They had 140 patients that were enrolled, but you can see they had a huge drop-off here as far as inability to manufacture, patient-related symptoms, and they progressed before they could get to treatment. So they only actually had 85 of the patients that were actually infused and evaluable for safety. 51 patients at the time they presented this were evaluable for response. And so you can see the little bit of differences here. I didn't show the data, but in the KITE study, because of the way they designed it, they had more patients that were actually able to be infused. The manufacturing time is also shorter for that product as compared to this, although they're kind of coming together, hopefully, and both being able to be less. So you can see that the adverse events in this particular study are with respect to the cytokine release syndrome, and the neurotoxicity seemed to be a little bit less in this study, and there were no cases of cerebral edema in this particular study. So there may be some differences in toxicity compared to the different products as well. So this particular study, the overall response rate was about 60%, and complete response rate about 40%. You can see that all patients that were in CR at 3 months remained in CR at the time of the data cutoff. So again, some of these can be very durable. And this particular methodology really helps as far as a global study because the product is shipped frozen to be able to manufacture that perhaps a little bit better, although it takes more time with this particular technology to do that. So interesting to see what happens with the different techniques and manufacturing products. The third one that was presented at Lugano and will be presented again is the Juno study. And this particular study, this is also shipped fresh, and this was presented by Dr. Abramson at Lugano. So in this study, they presented 91 patients were leukapheresed. You can see that they have some fall off here, and 67% of patients have been treated. And this study is perhaps a little bit earlier. They're trying to look at some of the different products and different doses, and so this is when it's not quite as far along as the other two. However, because of the way that they did have 98% of patients that apheres were able to make a product for. The overall survival that was presented in this, again, if the patients have a complete response, the majority of those patients have stayed in remission if they're in a complete response at 3 or 6 months. So I think this is going to be very promising as a class of agents. We just need to figure out what's the best patient population, the toxicities, how to prevent them or treat them, and to be able to utilize this in the best way for our patients, whether that's moving it up front, having this take over for autologous transplant in some patients completely, and cannibalizing some of the autologous transplant patients. Hard to know where this is going to fit at this point, but promising. So this particular study, the toxicities, I didn't really show that very much, but they were manageable, and they were pretty similar to the Novartis study. Did have some cytokine release syndrome, of course, and some neurotoxicity. This is an example of a patient that was treated at our center on one of the studies, and this was a primary refractory double hit patient. This is obviously all disease here on their PET scan prior to lymphodepletion, and this is 1 month after the CAR T-cell treatment at their 30-day restaging. This patient still is in remission now about a year after that, and I think that's pretty miraculous, where this type of patient previously we would never expect them to be alive a year later based upon any other therapies. So I think it's definitely going to have an exciting place if we can figure out where to put it and which product to use. That's, I think, unknown at this point, and lots of work yet to be done on that. There may be differential in using it in different patient populations, different toxicities, all yet to be worked out. And the other area is, how on earth are we going to pay for this therapy? You may have seen that the price of this, just for the product, the Novartis product they announced for the ALL study, which will be similar to the lymphoma, I'm sure, was $475,000 just for the product. That's not for the care of the patient or anything else, so that's going to add up to a lot of big bucks. And the KITE product was, I think, about $390,000, so kind of in the same ballpark. We're going to have to figure out how our healthcare system is going to be able to pay for these types of treatments. And then how do we predict the success or toxicity? And there's lots of work going on with that to look at the cytokines, perhaps pre-treatment or right after treatment. Did that predict for the response or some of the toxicities, and how do we differentiate these different therapies? That's yet to be worked out as well. There are several new studies that are, of course, looking at different targets. The myeloma CARs, a lot of other CARs are being worked on and look promising as well. So I think this is a technology here to stay, and definitely an exciting time in this particular area. So how can we predict response? There's a lot of work in this area trying to look at the peak IL-15 levels as an example to try to associate that with response. And there's a lot of work looking at what are the associations of toxicity as well. And can we predict the CRS or the neurologic toxicity? Neurologic toxicity is a little unpredictable. CRS is, I think we're understanding a little bit more about some of the cytokines or the types of patients that are more prone to get CRS, and hopefully be able to differentiate that with more patients being treated. So based upon all this information, we really need to understand the biology of the lymphoma to do adequate treatment, to try to differentiate different subtypes of treatment. And as we learn more and more, I think we'll be able to do that with some of this very, very basic information. But the problem is, because these are such rare patients, we're going to have to work together on clinical trials in order to do this, for sure. So some new areas that are interesting, I'll just point out just a couple areas that I think are interesting. Tazemetostat is an EZH2 inhibitor. It's an epigenetic regulator of gene expression. And this is a very important pathway in follicular lymphoma and GCB, diffuse large B-cell lymphoma. So there's a couple different EZH2 inhibitors that have been looked at. This particular one was also presented at Lugano. And this was a global study of different cohorts of patients with follicular or diffuse large B-cell. And this trial is still kind of ongoing, but I think has some interesting preliminary results. This is an oral medication, 800 milligrams BID. And what was presented there, although albeit a very small number of patients, the follicular lymphoma patients had a 92% response rate, and these were patients that had failed typically 4 or 5, up to, I think, 13 therapies. And the patients that were wild type still had a response, although much less. And diffuse large B-cell patients that had the EZH2 mutation had about a 30% response rate, and again, the wild type had a small response rate. So I think based upon this, understanding the biology again, may be able to utilize this in treating patients in the future. Much more data, of course, is needed for this particular agent. So programmed cell death inhibitors or PD-1 inhibitors or PD-L1 inhibitors, kind of the solid tumor folks have us beat on this a little bit, but again, we're understanding more and more the different subtypes of lymphoma where this may be important. So the areas that for this that look important would be primary mediastinal B-cell lymphoma, and this was presented at Lugano by Dr. Zinzani, where patients with multiple relapsed primary mediastinal B-cell had a pretty good response rate, some complete response with single agent, and 73% of patients had some reduction in the target lesions. And now that we're understanding this more, it's probably due to the chromosome 9 abnormality. And this same abnormality is often seen in some other types of diffuse large B-cells, such as testicular or CNS. And so that's probably something that's going to continue to be looked at in these types of patients, relapse patients as well. So going into the future, I think really we need to look at predictive abnormalities, some of these genetic abnormalities, some of these pathway abnormalities. And right now there's probably too much information, too much data to make a lot of sense of, but we need to be able to look at this to be able to choose our patients for different potential trials, looking at the pathways, and to try to subtype these. At least for our patients that go into trials, we need to make sure we're gathering that information and to be able to look at that retrospectively at the very least to go to the next trial, which is a prospective trial. And precision medicine, right now, of course, we treat all these different types of patients in kind of lump sums, but they're really different patients in these subtypes. So molecular diagnostics, I'm hopeful in the future, will allow us to choose different patients no matter what their histology is for different treatment options based upon this. And that's, of course, not today necessarily the norm, but clinical trials and in the future. And if they don't have any abnormalities, then standard of care. Let's hope that that is the case in the future, that we can use this type of methodology. And this is our new cancer center, the Buffett Cancer Center, just opened in June. And Chris was just there the other day. So this is a nice design in that they have all the basic researchers in this area of the building. All the clinical, inpatient, outpatient, radiation oncology, infusion clinics, radiology in this part of the building. And then all of our offices are here kind of at the juncture so that we can work together with and collaborate with the basic research scientists and translational research scientists. And then, of course, it's connected to the rest of the clinical centers and also to the research centers this way. So it's been a nice design, and we've really enjoyed it so far, although we're already out of office space, so we need more offices. But thanks very much for having me come and visit today, and be happy to answer any questions.
Guess is that of that 10%, only half of them had isolated CNS relapse. Most of them probably had systemic relapse at the same time. So how many patients do you have to prophylax? What's the ratio between risk? Because these are not benign procedures that are easy to do on patients who are thrombocytopenic. And it's not even clear that they work.
Yeah. So
where's the risk-benefit cutoff for how many you have to save with isolated CNS relapse versus how many you have to treat that will never happen?
Yeah, I think that's a good question, and it is always a risk-benefit analysis you have to do with that. So we usually use the NCCN CNS IPI, which kind of includes some different categories such as location, extranodal locations of the tumors and other things that also I think are beneficial. So if they have a high NCCN CNS IPI, we definitely would prophylax those patients. We actually have not previously prophylaxed the double expressor patients because of that very issue, that we have to prophylax so many just to have a few benefits. So I think that's yet to be determined, honestly. The other question is, should you do intrathecal prophylaxis, which we've traditionally always done, versus systemic methotrexate, like in a modest dose 3 or 3.5 grams per meter squared. I recently learned that basically all the German and the Europeans are going to systemic methotrexate prophylaxis and really don't use any intrathecal anymore because it probably is a better prophylaxis. Who knows? The tolerability is a little bit different, and when to do it is an issue. So I think some of those questions really need to be worked out. When do you guys use prophylaxis for diffuse large B-cell?
Yeah, so commonly in the double hit population, and then put together strategy using the CNS IPI combined with that. And double expressors, like you said, is a tough category to pick.
So it sounds like you do about the same way we do. And you use intrathecal or systemic?
And we move towards using systemic.
Systemic, yeah. So
in patients that you think can tolerate it.
Yeah, so I think we're kind of going in the same category. Hey, Ned.
So thank you for that great overview of lymphoma. One of the things that's striking, you showed all the mutational landscape that's characterized as large cell lymphoma, but the response to immune checkpoint blockade is really pretty limited, with maybe the exception of primary mediastinal, which is probably indicated related to the susceptibility vis-a-vis PD-L1 and its relationship to Hodgkin's. What about the lymphoma microenvironment, or the tumor cells themselves might limit the ability of intrinsic immune responses to that disease?
Yeah. So I think that's a great question, and we've been a little bit confounded as far as why the diffuse large B cells or some other types of lymphomas haven't responded very well to the checkpoint inhibitors. I think as we're understanding some of the genomics of that, now we're understanding that better. But I think that all lymphomas, the microenvironment is really important, not just the tumor cells. So a lot of the analysis we've been talking about just are the tumor cells. But specifically in follicular lymphoma and certainly in Hodgkin's lymphoma, I think the microenvironment is also equally as important. And there's just not as much information available on that, but I think that's definitely an area of research that needs to be done, particularly in those two. Diffuse large cell, maybe not as much, because mostly that's tumor cells, and for the most part, not always. And perhaps it's a little bit less important in that particular subtype, but lots of work to be done.
Julie, very nice talk, as always. I'll ask you a question about something that I know is near and dear to your heart in the T-cell lymphomas. And we now have means with gene expression profiling to sort of risk stratify patients and to be able to identify some of the targets for T-cell lymphoma that might be important. How can we move those towards the kinds of basic trials that you mentioned in the T-cell community?
Yeah. So actually I was going to talk about this at our meeting at ASH because I think we should think about that type of a basket trial as our multi-center collaboration that we have together to try to see if we can actually do that type of analysis similar to what they're doing in the TAPER study, where you kind of take any genomic analysis and then have a panel of different therapies that would be able to be utilized for the patient based upon what that genomic analysis is, as long as it was done in a CLIA-based laboratory. That's easy to say and much harder to do, but the TAPER study, which is from ASCO, I actually talked him into having B-cell lymphoma in that trial in myeloma, but they excluded T-cell lymphoma. So I would like to have us maybe consider doing that for T-cell lymphoma in our consortium. So I think the time's come to do that. Yeah.
Thanks for a great talk. I guess lymphoma is one of the prototypes for diseases where pathology ought to be reviewed centrally. And you've got the same issue, probably more than some of the rest of us do. So many tests and so little tissue, and it just it gets used up. I guess my question is, I'm asking you from your ASCO hat, is there any movement afoot amongst pathologists or in the lymphoma community to try to help us deal with the fact that we just have trouble getting tissue? I'm in melanoma. We have trouble getting the tissue from the outside.
Yeah.
And then when we do, it's used up.
Yeah, I think that there's several issues there. I think one is that more and more, of course, the patients usually get biopsied before they come to us, right? Because they already have that diagnosis. So a lot of times they have needle biopsies done now, which really are not adequate for lymphoma because you need, the architecture, obviously, to look at that. So we try to work with our referring physicians to try not to do that. Sometimes we have to rebiopsy patients, unfortunately, because you just can't get adequate tissue or it's used up. And I think the other problem, to be quite honest, is the pathology community is a problem because they have so many rules and regulations about what slides they'll send, what materials they'll send, and at least at our center, we get a lot of our patients come from other places. So we get a few slides on a patient, but they're inadequate for the diagnosis. Then we have to send those slides back and get the block because they won't send both at the same time. So I really think we need to work with the pathology community on that issue because that's a huge problem in our area as well. Yeah. Any other questions? Okay, thanks so much.